get ahead of myself sometimes. See here. Okay. With methotrexate, they use it orally most of the time. It's 4 to 6 weeks. It takes about 4 to 6 weeks to help. And so it can decrease the white blood cells and the platelets, and sometimes liver function tests and renal function can be affected. Mouth sores and patients in childbearing years, the strict birth control. So, because it is a cytotoxic, but that is a kind of a negative. But if the dose makes the poison in almost anything, and so it's usually really, really small doses. We actually had another faculty member, or the one that was taking the Orencia. She was on the methotrexate too, so you can take methotrexate for other things besides cancer. Okay, so we're going to go into some of these are going to be used for lupus too, but I'm going to go ahead and talk about them. Aspirin's a lot of times prescribed first. For one thing, it's inexpensive. You can get it over the counter. You don't have to worry about filing your insurance and all that kind of stuff. But it can be real effective at the point of inflammation, and it can be very effective with pain. Well, look at this dose: 3 to 4 tablets of 325 milligrams 4 times a day. Oh my gosh. We usually see those 81 milligrams, and what's that for? For 80, if it's 81 milligrams, you just, for platelet, you prevent the platelet aggregation. So what are they going to be at risk for when they take that much? Bleeding. Bleeding, yeah. And what about, I know people have been in my clinical group, we talked about aspirin, and where is the bleeding most likely to be?
GI.
GI, right. And why is that?
It affects the lining of the GI tract.
Well, and it's what? Right. Yes. And we have what's in our stomach? Acid. What kind of acid we got in our stomach? Hydrochloric acid, yeah. And so what is actually ASA is the abbreviation for aspirin. You know what that stands for? Anybody know what ASA is?
Acetylsalicylic acid.
What?
It's an acid.
Yeah, acetylsalicylic acid. So we got all this hydrochloric acid in there, and then you're putting all this acetylsalicylic acid, and then you got those blood vessels that are close to the surface, and you got your platelets not sticking together well, and all. So that they've got a big risk factor there, right? And it really works well for a lot of people, but I just get this danger thing, like it's scary. Ding, ding, ding. I don't like to see it, but it really can help a lot of people. But a lot of people have to go off on it because of the tendency to have they may have like nosebleeds and stuff like that to show up. Okay, so and in these bigger doses of aspirin, it also can affect your hearing. You could have ringing in the ears, and so that can be a reason that people might go off on it too, so that it's not affecting your sensory perception. And so if it's not tolerated or if it's not effective, some other drugs like ibuprofen and naproxen and indomethacin, have you ever heard of that one? It's called Indocin, is the brand name of it. I don't know. I think they still use that for RA, but we don't see that prescribed as much because it can cause bleeding and irritation of the stomach and all too. But Celebrex is a COX-2 inhibitor that they used to have Vioxx and Viaxin and several others in that category that they found out. Does anybody know why Celebrex is kind of it's what here? Cardiovascular, yes, it can be strokes or heart attacks or whatever, yeah. And they did leave Celebrex on the market, but they took the Vioxx and anyway, but they have more incidence of problems with cardiovascular, but that you still have risk of that even with ibuprofen and Aleve. It's just milder risk, and so the Celebrex was a little milder risk too, but it's much greater risk than for the cardiovascular than ibuprofen or aspirin or naproxen would be. So we got everything comes with baggage, doesn't it? Definitely. So anyway, and so what do NSAIDs do? How do they reduce the inflammation? They're anti-inflammatory. Yeah, we have prostaglandin synthesis. And what is prostaglandin? Yeah, that's what makes you have cramps when you're having your period. That's a prostaglandin thing, but it's an inflammatory mediator. I mean, it's an inflammatory substance. So that's one of those. So if you can block that, then that can decrease your cramps. Some of these same things people take for menstrual cramps, right? I sure did, back when.
I keep shaking my feet.
So, anyway, so if people are different, we all know that, and so it really is a trial and error thing as to which of these, what kind of cocktail do we have. It's sort of like fibromyalgia we're going to be studying soon. You got to figure out what's going to work for that particular person, and so you do have to have some sort of a trial and error. Try to get some of the cheapest or the safest or the best tolerated, especially. And let's see, if you're going to be taking any of those NSAIDs, it's really a good idea. And this is really my soapbox. A lot of these things on the over-the-counter drugs, it'll say if you experience gastric distress, then you might want to be taking it with meals or taking it with some food or milk. And it's like, why would you wait until you get irritated? And then you go to the doctor and say, it's irritating my stomach, and the doctor says, okay, you never take that again. And then you never get that relief that you once had. So if you can go ahead and take something, have something on your stomach, or make sure that your patient has something on their stomach when you give NSAIDs, even crackers or something like that, just so that it's not going to cause that irritation. And you can take those with antacids. Now you can't take your steroids with antacids. That's they kind of are opposite of each other. That they would just destroy the effects of the therapeutic intent. And you can use enteric-coated aspirin. It's more expensive than the powdery kind of aspirin, but enteric-coated aspirin would maybe be a better decision to make. And then NSAIDs can be toxic to the kidneys, and especially if somebody already has renal issues or is in one of those stages of chronic renal disease. That may be dangerous. And if you've got like multiple myeloma, if you've got extra proteins in your blood, and that's messing with your kidneys, and if you're taking other medications that can be toxic to the kidneys, like vancomycin or something like that, that can be hard on the kidneys, then you really can be at risk for some increased kidney problems. So you may have to watch that, especially if you're already vulnerable in some way. And you can also use like H2 blockers, the cimetidine and ranitidine and famotidine and all those. Those are over the counter, so you can certainly use those. Okay, so our corticosteroids, it can dramatically relieve our symptoms and appear to slow progression of the joints. So,
excuse me.
Inflammatory, we've already definitely So, if you're using it for a long time, then we've got the diabetes issue, and y'all are all aware of that, right? We've talked about this before, and an example of though is prednisone. And so, if you have a high dose for a short duration, they call that a pulse dose. You do that with some kind of chemotherapy, like for multiple myeloma and some lymphomas and things like that. We use them along with chemotherapy. and it actually does affect the cells, the cellular growth. And so that's called a short duration pulse treatment. And then you can have a low dose of chronic administration. And you see the corticosteroids a whole lot in what condition that a lot of people come in the hospital with is a medical problem. Anybody give an IV solumetrol to somebody?
Everybody.
For what?
COPD?
Yeah, because you really do see the COPD people taking lots of steroids, and sometimes they take like 5 milligrams of prednisone every day or every other day or something like that. Anyway, those people are susceptible to diabetes and such too as well. But and they are usually on that low chronic dose, but then when they have the exacerbation, they get the big guns, don't they? Right into the vein, right into their bloodstream. Okay, so you want to instruct them if you're taking it home orally to take it early in the day if possible, because it can cause insomnia. I don't know if we've really talked about that, but have you heard that steroids can cause insomnia? So if you're taking it orally, if you're taking it every 12 hours, you're just that's just tough. You just can be, nervous and such. But with if you can take it early in the day, if it's just a 1 time a day dose, it's better to take it when you can, so that you don't disturb your sleep as much. And in some situations, you can see that it can increase white blood cells as well. You can see that go up. I don't know really why that happens, because it says it depresses the bone marrow from making some cells sometimes. But I've seen that happen sometimes. So we have to watch the blood counts as well. And then we can have the poor wound healing. We have dealt with that before too, Pam. I think we talked about that in tissue integrity, that if you're on steroids, that's an issue. And it can cause some electrolyte imbalances as well, and it can leach calcium out of the bones. So, and it can also cause GI bleeding, and it is an irritant to the stomach, and it can happen with long-term use as well. So, usually try to limit it to low doses daily, but with an exacerbation, you're going to be getting bigger doses. And you have to wean off of the medication over days to weeks if you've had it for long-term use. Now, with those pulse treatments, sometimes people really did have problems, because we would give them like 80 milligrams a day for 5 days and then just stop. And some people really had problems with that, and we would have to take it down, but that was not the way regimen was written, because we just doing it, that decrease their symptoms. And we really, most of the time, the rule is to, unless it's a protocol of pulse doses, and you don't taper it down, it would be just over a short period of time, over just a few days, like 5 days or something like that. But if it's long-term, you definitely have to taper it down, because like we said yesterday, the adrenal gland is lazy, and it didn't come back in a hurry. It takes it a while to wake up and start getting some work done. So we can also see hypertension, fluid and electrolyte imbalances, and glaucoma. Sometimes you're susceptible to glaucoma. And it also can, I'm not sure if it actually is the cause of cataracts, but it can increase the progression of cataracts anyway. So that's an issue if you're on long-term corticosteroids as well. So and if you don't taper, you're going to have adrenal insufficiency. What are you going to feel like if you got adrenal insufficiency from you just don't have any energy. You might feel like you've been hit by a truck. I mean, that you just can't get up. You have no energy whatsoever. I mean, it's really profound in some people when they have that issue. And the electrolyte imbalances, you certainly can see that. Okay, so. Okay, the first group of medications. and they're all modifying the immune system, is really what that's about. And the inflammatory response might take weeks or months for it to settle in and actually work. So the immune and inflammatory agents, that's what you were talking about, the gold salts, anti-malarial, that's hydroxychloroquine specifically, and the social salad is one. I haven't seen it, but I don't work in that so often. So some people may still use that. And let's see here. With the methotrexate, there is an antidote. It's actually an antifolate, and it has to do with like what's in the DNA molecules. And so if you can actually use a rescue from the methotrexate if somebody has sore mouth or has side effects like gastric irritation or any of your mucous membranes get irritated. You can use folic acid supplements to try to control the side effects, but at some point though it's going to decrease its the way that it works if you do it at the same time. You can do it like give it in the morning, and then once it's gotten in your system and it's had a chance to start working, then you can do the folic acid. You have to talk to the doctor about that, but you can have a little bit of antidote from that. And those are stasis eye drops that when you don't have the chronic dry eye. It's cyclosporin, and that is one of those alkylating agents like cyclophosphamide. And the nitrogen mustard that we talked about in 112, and so it really is like a chemotherapy drug in a way, but it will decrease because of what's happening with that actual diagnosis of chronic dry eye. It is an autoimmune issue, and so you're trying to just putting it in the topical area. You're not going to get very much in your system if you just put it in the eye like that. So it's not going to lower your blood counts or make you get nauseated and vomiting and hair loss and all that kind of stuff. So there are some other drugs that we've talked about. We've seen on TV, Rava and Enbrel. Those are we talked about with Remicade. And Humira is a biological response modifier that's given sub-Q. And you can't give it to clients with active infections. Why is that?
That's what the immune system.
So what? Right. You won't be able to defend yourself against infection because you're suppressing the immune system, right? So, and then the gold salts, it can be effective, but they don't really know how that works. But it can put people into clinical remission and decrease the bubonic erosions. And then again, the hydrochloroquine is details on there. It can be really toxic to children. So you have to use it for about 3 to 6 months to start getting a good response. And then again, the retinal changes. It can be irreversible in some people. So if we're going to be doing teaching at discharge or in the doctor's office or whatever, we want to make sure that they are getting their eyes checked. And maybe not even give them a refill if they don't get their eyes checked, because that could be toxic, and you could be, the doctor could be responsible if they continue to order that and not verify that the eye exam is normal. So, and the sulfasalazine is something that you can take for chronic inflammatory bowel disease, sort of like Remicade, the Crohn's disease, and the RA both can respond to that, but it can cause some organ damage, bone marrow toxicity, and stuff like that. All that baggage comes with any medication. It's kind of scary, and everybody's body's different. All right, I do want you to know what these procedures are. Synovectomy, does that make sense? Synovial fluid area, synovial joints. So they're going to remove that membrane, that synovial membrane. So that's an ectomy for the synovial membrane. So when we're talking about arthro, what is that? That prefix? Arthro? arthritis, arthralgia. Yeah, it's a joint. Arthrodesis is when you're fixing a joint that results in a bone fusion. So it's a fusion of a joint. Then arthroplasty means you're making something new. So the plasty is making an artificial joint. You're restoring it or repairing it as much as possible to have the integrity of the joint. And because we see that with hip surgery sometimes, don't we? Arthroplasty. And then plasmapheresis is where you use a filter to remove that circulating antibodies. It can be done routinely. That works for the person. You have to they take the blood out and put it through a filter and filter those immune complexes out, and then give you blood back. And then the total lymphoid irradiation can have strong immunosuppressive effects. And that would probably be in a situation where everything else has failed and you're just absolutely miserable. So the synovectomy is usually on the knee or the elbow, and the arthrodesis, the cervical vertebrae and wrists and ankles, and the plasty is if you've got really bad deformity or joint destruction or bone break or something. Or repair it, and then the total lymphoid decreases the lymphocyte levels, but it does have serious side effects because that's going to mess with your bone marrow. Okay, so we want to have a balanced program between rest and activity, and that's sort of like our prioritization deal. Because you can't, even if you're tired, you shouldn't stop being active altogether because you get more fatigue. Like with cancer patients, we talk about in the cellular unit that most cancer patients do better if they do have some sort of exercise, and that they do promote exercise of some sort, at least, getting up and active and not just lying in bed. And then the physical and occupational therapy, of course, if you've got those distortions of your hands and feet or any other joints, and use heat and cold therapy like we talked about before, orthotic and assistive devices. What are some assistive devices we would yeah, you can splint, use a cane to walker, yeah. And you also, like those region things, if you can use your hands at all, to use the little grabber things. If you can't actually grasp like a can or something, you do have a little bit of motion to use the grabber thing. That may not work for everybody, but if you have some strength, that you might be able to do that. Let's see. So you can use hot showers and hot packs. You can use ice to the red and swollen and inflamed joints that are really hot. Or you can just put a pack of frozen peas or frozen corn on it for cold therapy as well. So you just don't want to leave it on more than about 20 minutes at a time. Just put it back in the freezer and then eat it the next day. It's get out of the cold. So you can use splints. And it will help the rest of the joints, especially if you have a flare-up. And the PT can improve mobility and prevent the complications of inactivity. Like, what are our complications of inactivity? What did you say? Yeah, stiffness. Did you? Yeah, muscle atrophy. Yeah, you can see that in some patients that come in the hospital. They're all contracted. And then we got DVT too, don't we? I mean, if you're just really just being still all the time, that's maybe not if you're taking all that aspirin though, but not everybody's taking aspirin. Okay, and so splints and braces are orthotic devices. And the canes, walkers, raised toilet seats, well-balanced diet, fish oils like omega-3s, and linoleic acid is one of the omega-3s too. And it can be from the seeds of currants and primrose. If you got like primrose oil and currency level. So those are omega-3s as well. And try to adapt the calorie intake to the activity levels, because one of the things that's going to be a detriment to you is if you're trying to walk is what if we're looking at diet and calories and all that. Because if you're real heavy, it's gonna weigh on your joints, isn't it? And some people have had to go get bariatric surgery to decrease the destruction of their knees and their hips, because they were too heavy to really get up, and their joints couldn't carry them in the condition that they were in. So, acupuncture, hydrotherapy, those are some of the things that you can do that are complementary. And let's see, anti-inflammatory diet is really suggested, mostly vegetarian with olive oil and fish, and no red meat and all this. That's the sort of like the Mediterranean diet. They do use fish, but people do seem to have less inflammation when they eat that way. And there's not a cure for this for adults anyway, but you can be real vulnerable to quackery, like cancer patients could be. People fly all over the world with these just sensational promises, like the snake oil salesman and stuff. And so that's something we have to advise our patients on, not fall for things that have not been evidence-based. And they spend a bunch of money, and then it doesn't even do anything for them. So it's desperate people do desperate things, don't they? They really do. Okay. Y'all can see those make a lot of sense. We've already really said those. Maybe not the anxiety. We talk about activity and tolerance, but there's probably lots more. The home maintenance impairment and the role performance alteration. You may have ineffective coping and lots of other things like that. So one of the things that I have read was that there's somebody that has an RA that we shouldn't perform their ADLs unless they ask us to, or we can ask them, what can I get you to get cleaned up? What do you need, or how can I help you? But to encourage them to be as independent as they can be. And then occupational therapy can certainly help with that. And if you can't grasp your toothpaste, you can use it, push it with the side of your hand, and put it on your toothbrush, things like that. Long-handled hairbrushes and dressing sticks. And this Hyde usually does a simulation on all of these kind of assistive devices and stuff. It's really, really cool. It's such simple, neat devices, but you just don't even think about using it unless you had a need for it. And you can really see how that can make people's lives better, to have a better quality of life and be able to do things for themselves. And then dealing with the fatigue, we talked about the prioritizing, and you need to check for anemia. You need to get on supplements if necessary, and of course the iron supplements aren't gonna help, but they may be able to find other ways to build up their hemoglobin. And then PT for the strengthening of the atrophy muscles, adequate rest and sleep, and it's better to do regular exercise. I think this was pretty good. Yeah, and if it takes over an hour to get moving in the morning, and then you get tired early in the day, then you're kind of out of balance with your life, and you really can't have a life. So that's what we're going to try to get them to be as independent as they can be. And preparing for self-management charts. know it's chart 18-10 in the 8th edition, and I don't have the other one. But anyway, it is any of these things that, like home care, what you want to teach people for home care, those are things that be good to look up in the book. So, okay. And this is longer than the RA. The RA was longer than the lupus because there are a lot of similarities. So you don't have to be so careful. Maybe some of the differences. Okay. Okay. So what? Does anybody know what lupus refers to? What's that Latin word? Yeah, sure. Sure is. So SLE is systemic lupus erythematosus. What is erythema?
Red.
Red, yeah. So it's a chronic inflammatory connective tissue disease affecting almost all body systems. Well, what about RA? That sounds like the same thing. But, yeah, it's a whole different thing. Yeah, it really is different. But there are some similarities manifestations. And it's because of the antigen antibody complexes in the connective tissues with those type 3 hypersensitivity reactions. So, what you may see, there's autoantibodies that are in response to the nucleic acids and other components in the cell nucleus. So, you can test for anti-nuclear antibody with lupus, and you can see spontaneous remission, exacerbations, little flare-ups too. You call it a flare-up in lupus or in RA when it gets worse. And so I think I'm going to go on and do the little videos now about people living with some of these issues.
She's had the joint-destroying disease for 30 years. These are the hands of rheumatoid arthritis, and they belong to Regina Hamilton. She's had the joint-destroying disease for 30 years.
I actually had these metacarpal joints replaced with artificial joints, and I also had a screw placed in my thumb.
Rheumatoid arthritis, or RA, affects at least 1.3 billion Americans, women more frequently than men. It's considered an autoimmune disorder, meaning the body, for unknown reasons, begins to attack its own joints. In this way, RA completely differs from what many might consider the classic arthritis of older age, osteoarthritis.
Well, osteoarthritis is what we typically think of as sort of wear and tear type arthritis. Rheumatoid arthritis is an inflammatory joint disease that affects typically smaller joints. We're pushing in the wrist joint itself, looking for swelling or tenderness.
That would include, most especially, joints in the hands and, very commonly, in the feet.
Patients will say that they wake up and they're very, very stiff, and that stiffness lasts for a half an hour, maybe an hour or longer, until they get in the shower. They sort of limber up over time and then start to feel a little bit better.
That stiffness indicates an inflammatory process that can lead to joint destruction. But rheumatoid arthritis is not just a joint disease. The inflammation can affect other body parts as well, most importantly, the heart.
The link between the cardiovascular component and the inflammatory component is getting stronger and stronger. And the cardiovascular mortality is a major, major part of the mortality associated with rheumatoid arthritis.
In fact, the American College of Rheumatology estimates a 30 to 60% higher risk of a cardiovascular event in RA patients compared with the general population.
And given some of these risk factors, it probably makes a lot of sense for a rheumatoid arthritis patient to be eating healthy, keeping active, and being physically active, keeping the weight under control.
RA can still be a crippling disease, one that might even require surgery. But the outlook for most patients diagnosed now is considerably brighter, thanks in large part to a broad array of drug treatments.
It is a very rewarding feeling to have a patient come in the office and say, you know, Doc, I went golfing for the first time in 5 years, or I woke up and I wasn't exhausted and I was able to brush my teeth and button my clothes or play with my children or lift my child.
As with any medication, patients may experience side effects, so it's important to work closely with your doctor. For Regina Hamilton, treatment has had a quick and positive effect.
Within 3 weeks, people that knew me were coming up to me and saying, "You look like you're walking better. You look like you're more comfortable. You know, you don't look like you hurt as much."
Hamilton also uses yoga, massage, and reflexology to keep her RA at bay. And she says it's important to maintain a positive outlook.
I think everybody has a challenge. And, you know, mine's a little bit more obvious. We all come into this world needing to learn something from a challenge.
In Boston, Jim Morelli for CNN.
The pathologic hallmarks of rheumatoid arthritis include inflammation of the joints, particularly the small joints in the hands, wrists, and feet, accompanied by cartilage destruction and bone erosion. Underlying inflammation leads to many of the characteristic signs and symptoms of RA, such as pain and swelling of the joints. Inflammation results from abnormal propagation and activation of many types of immune cells, resulting in the secretion of cytokines and other mediators that sustain and amplify the inflammatory environment. As a key pro-inflammatory cytokine, TNF-alpha, along with other cytokines, activate immune cells, including macrophages, as well as other cells, such as synovial fibroblasts. In a key step, activated macrophages and synovial fibroblasts release pro-inflammatory cytokines, including TNF-alpha, IL-1, and IL-6, and mediators of vascular growth, including VEGF. VEGF is essential to the process of blood vessel proliferation, or angiogenesis, which facilitates an influx of activated cells. These cells contribute to the growth of pannus and sustain the inflammatory cycle. The growing, vascularized pannus develops villous projections that result in better access to the cartilage and bone, and therefore greater opportunity for the activated cells to release damaging inflammatory mediators and enzymes. In the interface between pannus and cartilage, activated synovial fibroblasts and macrophages are a source of enzymes that degrade the cartilage matrix. These include MMPs, or matrix metalloproteinases. Thus, activated cells in pannus are key instigators of cartilage destruction. Chondrocytes are the main cellular component of cartilage and normally produce the extracellular matrix. However, in response to stimulation by TNF-alpha, IL-1, and other inflammatory mediators, chondrocytes become activated in the rheumatoid joint. Activated chondrocytes secrete more inflammatory factors and more metalloproteinases, MMPs, which aggravates inflammation and cartilage damage. The cumulative result is irreversible cartilage damage and joint space narrowing. Under normal conditions, bone remodeling involves a tightly regulated balance between bone resorption and bone formation. However, excessive TNF-alpha helps stimulate osteoclastogenesis and bone destruction. In the marrow, TNF-alpha helps stimulate monocyte differentiation into osteoclast precursors. At inflamed joints, in the presence of macrophage colony stimulating factor, TNF-alpha, and rank ligand, osteoclast precursors differentiate into mature osteoclasts. resulting in bone resorption. Thus, the direct and indirect effects of the TNF-alpha on osteoclast maturation and activation culminate in focal bone erosions and irreversible joint damage. As we have seen, TNF-alpha plays a key role in the complex pathology of RA. One cytokine, multiple effects.
That was pretty complicated. That we did show you, I like the picture. Pictures are fine. You see all that other stuff that we haven't even addressed. There's so many factors that come into play.